One of the most interesting and exciting areas of research right now today is this area of adjuvant therapy for high-risk kidney cancer patients, patients with stage 3 disease who we know have a significant chance of disease recurrence sometime over the next 5 years, many of them recurring within the first year following nephrectomy. How do we manage those patients? Historically, those patients have been managed by observation alone. Today, we have some clinical trials looking at immunotherapies, either prior to nephrectomy and after, or following nephrectomy, versus observation alone in that space. But we also have an FDA approval for adjuvant Sutent based on the S-TRAC trial, a phase 3 study that demonstrated a 24% reduction in the risk of disease recurrence over a 5-year period of time. And that was also associated with an absolute improvement in disease-free survival of 8% at 5 years. It was associated with a year's worth of treatment with sunitinib, which had toxicities, and 28% of patients weren't able to tolerate that therapy. So it's a standard of care that I would say has been offered in select patients, patients that we think can tolerate this therapy, and patients that are motivated to do this treatment and at all cost. Many of the patients in the S-TRAC trial were young and healthy going into that study, and that's probably the patient population we should be focusing on. But certainly not something we have to treat every patient with, but I think every patient needs to hear about it. Alternative to that would be the clinical trials that include the placebo-controlled observation. So with that, I'm going to turn to my colleague, Toni, here to get his thoughts on this adjuvant space, both in terms of clinical trials and standard of care.
Thank you, Dan. You know, this is a hot topic area, and I'm glad finally we have some action in the adjuvant setting. You know, despite the disease-free survival advantage with sunitinib in the S-TRAC study, let's not forget there are other studies with different eligibility criteria, like the ASSURE study that used sunitinib and didn't find that effect. And so far, we have a total of 3 adjuvant studies with VEGF TKI, including pazopanib, which at least in the metastatic setting is not superior to or is not inferior to sunitinib, and most recently a press release from Pfizer about axitinib showing no effect. I think in selected patient, perhaps after a discussion with the patient about the pro, cons, and the meaning of the endpoint, you know, it may be reasonable to consider it case by case. I think overall the future will tell us if this practice of adjuvant sunitinib will pick up. Let's not also forget the rest of the ongoing adjuvant studies, one with everolimus from SWOG, that finished accrual, and several other with checkpoint blockers that may give you a chance for a disease-free survival that may translate into overall survival. I think overall survival should be the gold standard in adjuvant studies if possible, because a lot of these patients, you take their kidney out, we know they're at high risk of recurrence, but a lot of them, over half, are already cured. So exciting field, certainly. And I would like to know what Walt would think about a patient that stepped today, young patient, stage 3, intermediate grade, but negative CT chest or other, you know, post-nephrectomy, but negative metastatic workup.
Yeah, so I discuss the data, but I don't encourage adjuvant treatment with sunitinib, much for the reasons that you've mentioned, other trials that have not shown an advantage. And we have to recognize it's a real toxicity. Giving these VEGFR TKIs in metastatic setting when you may have tumor symptoms and there's a potential for relieving tumor symptoms is one thing. Giving them to asymptomatic patients for a year long with all the attendant toxicities, I think the burden of proof, as you said, really does need to be on survival. And in essence, I think we've voted with our feet in the sense that the adjuvant immunotherapy trials that you have mentioned are all placebo-controlled, and we should only participate in those if we ethically believe that the placebo is an appropriate treatment. In other words, that surveillance by itself is appropriate, and certainly I believe that.
Bob, what do you think? What do you practice in Texas?
I prefer to use adjuvant treatment for the high risk And the intermediate risk, I'll go through it with the patient and the family that's present, but I'm ambivalent. Again, the high risk patient or the poor risk patient, I'm less ambivalent and more likely to be proactive at considering a TK. Now, but the landscape keeps growing now, and my concern is we're still looking at old school clinical characteristics, size of tumor, grade, pathology. We all have, I would imagine we all have molecular pathologists. We just recruited 2 for our urologic program. That's their focus. And to study these primary masses, whether it's kidney, bladder, urothelial diseases, upper tract diseases, to help us decide who molecularly is going to be that bad patient. And they deserve an adjuvant study or an adjuvant agent that has approval. But to me, it's selection. We know in these untreated first-line patients, it's not a high percentage of patients that are benefiting. It's a percentage of patients. It's not 90% improvement rate. We're delaying the disease progression. We're delaying new onset of disease. And in many cases, we're all seeing some regression.
And I think that really sort of speaks to the fact that there's, a need for these ongoing studies to begin to, select patients appropriately.
Rich, I would like to get your opinion.
Yeah.
I agree. I would like to get your opinion first about the adjuvant field. Someone steps to your clinic tomorrow. And also remind us, we didn't discuss that, but I'll leave it up to you to finish. The M1 in ED setting. Patient come with, 1 metastasis, resected, and would do that different than what the studies S-TRAC and others showed. So start by your point of view about adjuvant.
Sure, adjuvant therapy in kidney, I think, I'm personally a believer if you're going to give an adjuvant drug that has toxicity, that you need to be improving survival. Whether that's right or wrong, that's just what I think. And I think, through, one of your papers, one of our papers, using meta-analysis showing all of these studies using VEGF TKIs in the adjuvant setting, we can't even get a hint or a whiff of survival, or with meta-analysis, even disease-free survival. So to me, the data is extremely weak in support of giving adjuvant, and the toxicities are real. I agree with the panel that, yes, there are those patients out there that are high risk and are going to recur, and maybe you're going to feel better. But to me, I guess I'm questioning, well, am I actually doing them better by giving them an adjuvant agent that doesn't improve survival, or should I just wait until they have something and then treat them with something that I know will cause survival? So I think that's the struggle that I have in the conversation with the patients. In regards to the M1 data, that study is, I believe, being presented here, and looking at sorafenib after the M1 resections, and not showing any true benefit there. So I think it's, extrapolating from the pure adjuvant setting to the M1, doesn't seem like VEGF is very important, at least in the adjuvant setting. Maybe it does slightly prevent, but it's not leading to cures. And I think really, when you're talking about adjuvant, cure and improving the survival at 5 years is really should be the goal.
But I think that to your point here in regards to some of the trials and things, I think we should remember that not only are there adjuvant trials in both the M1 and the locally advanced setting, there's a neoadjuvant trial now as well, a NCI supported trial, and this just sort of speaks further, I think, to the increasing critical importance of collaboration between the surgeons and the medical oncologist in terms of the treatment of these diseases, And we spoke about this a little bit earlier, where there's a need for biopsies, there's a need for participation in these clinical trials from both disciplines, and there may even be theoretical reasons why the neoadjuvant, at least in the immunotherapy setting, may be a better setting. So I think that one of the other major changes that has occurred over the last few years, and that has been part of the discussions at this event here, is the increasing need for collaboration between urologists and medical oncologists.
And I agree, and this is the only, academic, trial that doesn't allow placebo. It's observation,
Right.
so certainly easier. And as a reminder, some of these adjuvant immuno-oncology studies currently ongoing and accruing do allow M1 in ED.